In the introduction, we looked at some of the issues and defined some of the key terms related to the discussion of ethical issues related having to do with end-of-life care. In this presentation, I want to explain what I call our fragile moral consensus about some of these matters. It's a moral consensus because there is broad agreement in our society about the matters that I will name. So there is a kind of consensus. It is a fragile consensus, however, because significant dissent or disagreement about some of these matters exists around the edges. So it is a consensus, but it is not something that is finally or forever settled among us. The first thing about which there is broad general agreement is that competent adult patients have a right to refuse treatment, including life-sustaining treatment. This, of course, reflects our commitment to autonomy or to respect patient autonomy. And you will recall that no medical intervention is legitimate unless it's based upon informed consent. The key idea here is this extends to life-sustaining treatment. We may not coerce or manipulate a competent adult patient to accept life-sustaining treatment. We may not force such treatment upon them. A second part of the fragile consensus is the idea that allowing patients to die, or passive euthanasia, is sometimes morally permissible or even obligatory. Now, be clear, this really does add something to what we've said first. Recognizing that a patient has the right to do something does not mean that what they do with that right is morally correct. But here I'm adding the idea that there is a broadly shared agreement that sometimes refusing life-sustaining treatment is the right thing to do. Now, this is important particularly when we're thinking about making decisions on behalf of those who cannot make decisions for themselves. Sometimes it is broadly believed, sometimes it is perfectly acceptable to decide for another that a life-sustaining treatment is inappropriate. Third, there is very broad agreement that there is no significant moral difference between withdrawing a life-sustaining treatment once it's started and withholding that treatment in the first place. Now, this is significant because there does seem to be an important psychological difference. It's much harder on us, much more difficult for us to stop a treatment, take a person off a respirator, let's say, than it is for us never to start it. It seems there's a closer relationship between our action and the person's death when we withdraw a treatment than when we merely withhold it. Still, most ethicists agree, if not all, that there really is no moral difference between the two actions. Finally, you should be aware that there is broad agreement with the idea that the permissibility of removing life-sustaining treatment includes artificial nutrition and hydration. By law, in most states, and certainly this is true in Virginia, a patient may refuse, or the surrogate decision makers may decide for a patient not to start or even to stop artificial nutrition and hydration, just like any other life-sustaining treatment. We will look more deeply at this issue later in the unit. Now, let's look a bit more deeply at significant aspects of this consensus. First, let's think about the patient's right to refuse treatment, including life-sustaining treatment. The Council on Ethical and Judicial Affairs of the AMA says the principle of patient autonomy requires that physicians respect a competent patient's decision to forego any medical treatment. This principle is not altered when the likely result of withholding or withdrawing a treatment is the patient's death. The right has been upheld in the courts and is generally accepted by medical ethicists. This recognition of the patient's right to refuse treatment is surely grounded or has its basis in our commitment to autonomy. We have been saying throughout this course, our capacity to think, choose, value, and act for ourselves is thought to be an essential dimension of our nature as human beings. And as a result of that, we recognize an obligation not to coerce or to manipulate people, and an obligation to cooperate with people's autonomous choices, particularly in a medical context. So deeply entrenched is that sense of the obligation to respect patient autonomy, that even when a patient makes a decision that will hasten their death, it is generally believed we ought not interfere with that decision. Now, do notice it's limited to competent adult patients. Obviously, we are not going to recognize the right of a patient to make such a decision if they lack the ability to think carefully and critically about the decision they are making. And we would not necessarily respect the right of children to do this under the idea that they have not yet developed their critical thinking and reasoning capacities. But for the competent adult patient, the right to refuse treatment, even life-sustaining treatment, is broadly recognized and accepted. Now, the recognition of this right does not change given the varying contexts in which such a decision might be made. These varying contexts will be relevant to our thinking about what the right thing for a patient to do may be, or what is right for us to do when we are deciding for a patient. But the first thing to realize is that sometimes the decision to withhold or withdraw a life-sustaining treatment occurs in a context in which that treatment only prolongs or extends the dying process. It does nothing to cure or to heal a person. Sometimes that life-sustaining treatment is in a medical context when all it will do is continue a severely compromised existence. That is to say, a life that many of us would say is a life of extremely low quality. Sometimes life-sustaining treatments only extend life in such a situation. But sometimes life-sustaining treatments are in a context in which that treatment, along with others, may lead to a return to full health and to an extremely high, or at least widely acceptable quality of life. A quality of life that any of us would agree is worth living. The context in which such decisions are made will have a great deal to say, or will have great influence over our judgments about whether such a decision to withdraw treatment is morally appropriate. But continuing to think about our recognition of the right of a patient to refuse life-sustaining treatments, we should be aware of the possible conflict between this commitment grounded in autonomy and our recognition of obligations grounded in beneficence or fidelity. The obvious question here is this: isn't a life-sustaining treatment in a patient's best interest, particularly when a return to health is possible, or even when it sustains a life of some acceptable quality? And don't healthcare professionals have a particularly strong obligation to provide care that benefits their patients? Surely they must respect patient autonomy, but they also must use their skills in ways that make patients better off. So some would argue that medical paternalism, overriding a patient's autonomy in order to promote their own welfare or to preserve their life and restore health, that medical paternalism is sometimes justified, particularly in a context where a return to health or sustaining an acceptable quality of life is possible. Please notice, however, that a very important article by the Council on Economic and Judicial Affairs of the AMA in our text suggests that this conflict between autonomy and beneficence or fidelity may not be as great as we think. The first thing that they point out is that many life-sustaining treatments are extremely burdensome and invasive. That is to say, while they offer the benefit of extending life, along with those benefits are tremendous burdens in terms of pain and suffering, in terms of interfering with normal life functioning. That means they may not be so obviously beneficial. You should recall in this context our discussion of informed consent. And you remember the surprising conclusion, or surprising to me at least, of the President's Commission that the fundamental basis of informed consent is patient welfare rather than autonomy. And there they argued that the patient has the best perspective on what is truly in his or her best interests, given that those interests are more than strictly medical. So yes, it may appear to us as professionals that a life-sustaining treatment is in the patient's best interest, but it's only the patient who experiences that sustenance of life within the broader context of their existence. And that may completely change our perception of what is in the patient's best interest. Or put differently, the patient's perception may be radically different from the healthcare professionals. And so the AMA reminds healthcare professionals, and particularly physicians, that they are only obligated to offer sound medical treatment. And they do not have an obligation to impose treatment, even treatment that the healthcare professional thinks is in the patient's best interest. They do not have an obligation to impose that treatment on an unwilling patient. Now, while I am in complete agreement that the conflict between autonomy and beneficence may not be as great as it first appears, that we should not ignore that potential conflict. Our concern in thinking about these issues should be both about patient autonomy, surely, but also about standards of sound medical practice and professional integrity. I think it's appropriate for us to worry that giving complete rein to patient autonomy sometimes puts healthcare professionals in a situation in which they feel profoundly that they are not offering their best care. They are not offering and providing what is consistent with their own sense of what it means to be a healthcare professional. I think we should take that very, very seriously. I think we should also guard against the tendency to accept patient choices as competent or autonomous, especially when those choices seem obviously unreasonable. There is no professional obligation to be an agent of suicide. And so it's reasonable to question the decision of a patient where it seems that they are not simply foregoing a burdensome life-sustaining treatment, but rather they are actually seeking death. We should also be slow to accept every decision that a patient makes, recognizing that they may be impaired by suffering, by a sense of hopelessness, and a fear of abandonment in the medical care context. rather than simply accepting at face value a patient's decision to forego what appears to us to be an obviously beneficial, life-sustaining treatment, rather than accepting those at face value, we should inquire deeply as to the basis of that decision, and whether there is an irrational fear of the suffering that's before them, and our ability, and a failure to appreciate our ability to manage that suffering. We should also help patients explore the possibility that they're overwhelmed by a sense of hopelessness in their situation, and it may be incumbent upon us to help them redefine what hope is. They may have no hope of returning to a full quality of life, but they may have great possibilities for a life that will come to be acceptable to them. And a final consideration that always has to be kept in mind is that patients may not be making an autonomous choice, but may be refusing life-sustaining treatment under duress from family. Duress that is valid or that they are perceiving. How many times do we hear people, elderly people, say, "I don't want to be a burden," but maybe our families are perfectly willing for us to be burdens to them. Well, the point here is simply that we should not necessarily be quick to accept a patient's refusal of life-sustaining treatment. We are under obligation, I think, to explore with them the basis for that decision, particularly when it seems to us to be irrational, when it seems to us to be clear that the life-sustaining treatment is in fact in their interest. Okay, this time we've looked at some of the issues related to the right to refuse treatment. In the next part of this initial presentation, we'll look at the idea that sometimes it is in fact perfectly permissible to refuse or to not provide some life-sustaining treatment.